This is Dr. Janson, and I thought I'd make a little video to show you what it's like to make a pair of orthotics in my workshop. And this is a very good example of a patient that really needs a handmade orthotic. And the reason why I picked this patient as an example is because you see, if I make a line here along the side of the heel, and then I put a stick here to show, you know, the bisection of the heel, and then we showed the bisection of the front of the foot here, and then I'm going to put a stick like that to show the bisection, and then we see the angle between the front and the back. So that angle right there, that's about 30-35 degree angle in the foot, and this is in the transverse plane. So you see the curve of the foot? That's pretty clear. And that's called metatarsus adductus. That's a transverse plane variation in the anatomy of this patient's foot. This is Sarah. The other problem with this foot is that Sarah's foot, the heel bone is higher than the ball of the foot. So when Sarah steps down on the ground, there's a lot of stress on the top of the foot, and that's called anterior cavus, and that's in the sagittal plane. And Sarah has another variation in anatomy, and that is that her big toe joint is lower than her little toe joint, her fifth toe joint. So that kind of orientation is in the frontal plane, and that's called forefoot valgus. So this is a three-plane variation in the anatomy of the normal foot. So this is a very good example of a patient. This is the negative cast. The patient put her foot there, and I held it very straight, so her foot was straight to her leg. And now I'm going to make this orthotic as an example. Now I'm altering the negative cast here. Here I'm making the toes smooth because we want the orthotic to be smooth inside the shoe. Day 2, we've let the plaster cast sit for 24 hours so it can dry. Now it's very nice and hard, and it's really nice and smooth. And the first thing we do is write the patient's name, so we don't forget who we're working on here. So this is the blue foam is the negative cast. I like the foam method for most patients, actually, because as the foot goes into the foam, the foot widens and the heel pad flattens out as it goes into the foam. And that's good because that's the shape of the foot when you're walking. So of course you would want the orthotic to be mirroring the shape of the foot while it's walking, not the shape of the foot while the patient is sitting. Just like trying on shoes, you're going to walk around. So we're going to take the cast out now, bring it over to the garbage, because we're going to ripping away the negative cast, and now we're going to be left with the positive cast. now we have a clean cast, and we're going to change this cast. Now you noticed when I was, just before I poured the cast, I altered the negative. So what I did was I made this part of the foot more prominent to take the pressure off of here, because this is a anterior cavus foot, so there's a lot of pressure at this point, so I made this bigger to take the pressure off it. So, and this is because I altered the negative. I also lowered this on the negative, which makes it higher on the positive, but I'm going to alter it even more now on the positive cast. Polish it off later, but now I'm going to alter the cast. So the first thing I'm going to do is I'm going to make this part of the cast even higher. Now remember I told you that Sarah has 4-foot valgus, so that means that the big toe joint is lower than the little toe joint, so when she walks the foot flips over this way. And her problem, the reason why she came to see me is because for years and years she's had terrible ankle pain, because of course when the foot keeps flipping inward, the outside of the ankle is under a lot of tension and gets injured. So what we want to do is we want to stop the foot from flipping, and that's because of the 4-foot valgus. So we want to make the big toe joint low and then put material up through the metatarsals 2 through 5, with 5 being the highest. So I'm gonna add to the big toe joint now. So I'm adding plaster. So I'm making this even higher. So in other words, I'm sort of making her problem worse on the orthotic. But by sort of making the ground crooked as she walks on the orthotic, the foot will think it's straight, if that makes any sense. So I'm adding quite a bit of plaster here, because we're going to make it, we're making the foot worse. And this is the problem with 3D printed orthotics and whatnot. They're using the actual shape of the foot, but you don't want the shape of the foot, because that foot has a problem. You want to change the shape of the foot so that the orthotic fixes the problem. Plaster, so I'm making the angle of this higher. So this is the high point of the cast now, and that's to correct the ankle pain. And this part of the cast is built up to correct the fact that the stress is on the top of the foot, because the front of the foot is lower than the heel. And now I'm going to carve the cast. I'm going to remove plaster. And that's to help correct for the fact that there's also a angle between the front and the back in the transverse plane. So I'm going to correct for that by removing plaster. And what this does is, instead of the foot flaring out like a Japanese fan, by pushing it up just behind, it brings the metatarsals back together so they don't angle away from the heel. So this is the longitudinal support that supports the metatarsal. So this part of the orthotic will be high because I'm making it low on the positive. And this is to correct, again, to correct the metatarsus adductus. I'm going to make it very long and a lot of surface area so that it doesn't hurt the patient. This is the positive cast, has been altered. Plaster added and plaster removed. And now this has to dry for a day so that the new plaster becomes one with the old plaster and it doesn't break when I make the orthotic. So it's ready for tomorrow. And I also have to, of course, I have to make the other foot. So this took me about an hour and I'm going to do the other foot. So I'm about approximately 3 hours into the job so far. Okay, day 3. I almost always on Sundays make the orthotics, and my cast is ready now. So for this foot, this is a high arch foot. We want a rubbery material because this foot hits hard. So I'm going to use this material here. It's called ethyl vinyl acetate, and it's a very dense material. But it'll last a really long time. Should last 8 to 10 years, this pair of orthotics with this very good quality material. So I'm going to cut the top. It's kind of awkward. Very dense material, so it's hard to cut it. But the good thing is, that's why it lasts a long time. And I'm going to put this in the oven. I'm going to melt that. This foot first. Put the cast into the press. So that's the top layer. That's the layer that'll go next to the foot. And then I'm going to build the body of the orthotic out of this material. This is latex rubber, which is from a tree, mixed with sawdust, pork sawdust. So it's 2 tree products. And this is going to be the body of the orthotic. And I have to melt this too. So this takes longer to melt, so I'm going to put this in the oven with the top cover. Stick it right underneath there. And now I'm going to put on a glove because those materials are really hot. They're about 350 degrees of hot liquid plastic. Okay, so now the rubber is very soft. It's also very, very hot. the top cover of the orthotic. Cement. Dry it. Latex rubber with cork. It's bigger when it gets hot, so we trim it. These are not ready for the patient because these are giant. And what I'm going to do now is I'm going to grind this material, and when I do it I'm going to change the angle of the orthotic as I grind it. So remember, we want to make this low and this higher, so we're going to grind a little bit on the outside of the foot but more on the inside under the big toe joint. So that way the foot is supported and it can't flip anymore. You see that? About only halfway done with grinding this, believe it or not. But I have to get my bearings and make sure that I'm at the right angles here. So we know that we want the big toe joint to be low, so that when Sarah walks on the orthotic, the big toe joint has a place to go and the foot can't flip inside, so she can't keep spraining her ankle anymore. So I have to make sure that I have this angle. I don't know if you can see it with the camera, but this is thin here and this is thick here. So, or in other words, this is lower and this is higher. This point is higher. So now her foot can't, she can't flip over anymore. And then we want this point, this to be thin right here, because this is the apex between the middle of the front and the back of the foot. So that has to be thinner there. And then we also want to make sure that the heel cup, we keep her with a little bit more material on the outside, because this prevents her from spraining her ankle. And the inside of the orthotic is smaller and thinner. You can see, so that looks about right. And I have to fine tune this and make it look nice. But we're about right with the angles on it. You can see the weird angle of the back, but this way she can't sprain her ankle, because this part of the orthotic, this is the outside of the foot, is high on the orthotic. Okay, back to grinding, now that I know where I am. Okay, so we're finished with all the work that's done in the workshop here, and now the orthotics will go to the workshop in the city where my office is, and I'll meet Sarah, and I'm going to put the orthotics on her feet and then fine-tune the orthotic with what I don't have here. I don't have her legs here, so I have to make sure that it's lining up with the rest of her body, and that work will take me about an hour to do the last 10% of the work. So these are relatively large orthotics compared to other orthotics that I make, but Sarah had a terrible problem, pain with walking, and with the unstable ankle and the chronic ankle sprain, she actually had a number of falls, which is very dangerous, and she was told by a surgeon that she needed surgery. So these orthotics, she has to wear them only in sneakers, which is bad. And she'll probably have to consistently wear them for about 3 months. But then her ankle will start to feel better. We can prevent falling. And then after 3 or 4 months, then she'll get back to her regular activities, her regular sports, and be able to switch off into other shoes a few days a week. And only have to wear these maybe 3 or 4 days a week. So that's how I made a pair of orthotics, and I hope you enjoyed watching that.